So in this video, we'll talk about different types of arthritis and the hip joint as well. First, we have rheumatoid arthritis. This will affect the small joints of your hand and can also cause synovitis. Patients will complain of prolonged morning stiffness, but this will get better as they start using and moving their hands more. Rheumatoid arthritis will affect the PIP and the MCP joints of the hand, and it'll spare the DIP joint. Rheumatoid arthritis can also affect the cervical spine, and if it does that, it can cause a couple things like subluxation, cord compression, or atlantoaxial instability. Two antibodies very specific for rheumatoid arthritis are anti-citrulated protein and the FC portion against the IgG antibody. First-line treatment for rheumatoid arthritis is methotrexate. Remember that methotrexate can cause folic acid deficiency, so you'll have a high MCV. And to mitigate this, you can give leucovorin and folinic acid. Two big side effects of methotrexate are pulmonary fibrosis and hepatotoxicity. Osteoarthritis will affect the PIP and the DIP joints. People with osteoarthritis will have brief morning stiffness, and their pain will get worse with activity. Some risk factors for osteoarthritis are obesity or prior joint trauma. If you were to do an X-ray, patients with osteoarthritis will show a loss of joint space and will also show some osteophytes. The first-line treatment for osteoarthritis is weight loss and exercise, since a big risk factor is obesity. In the clinic, you probably saw a lot of patients getting steroid injections for osteoarthritis, but this is not first line. It's not what the boards want. If weight loss and exercise is not enough, you can also prescribe topical or oral NSAIDs. Next, we have reactive arthritis. This usually follows a GU or GI infection, and the most common causes are bacteria like chlamydia, salmonella, shigella, yersinia, and campylobacter. If you were to aspirate the joint, you would see a high white blood cell count, but a negative culture. Some other manifestations of reactive arthritis, if you watch Sketchy, you would remember the mnemonic: can't see, can't pee, can't climb a tree. This refers to uveitis, urethritis, and Achilles enthesitis. Another fun fact is if you are HLA-B27 positive, you're more likely to develop reactive arthritis if exposed to these bacteria possibly. And for treatment, you would just prescribe antibiotics that would treat the specific bacteria, and you can also give NSAIDs. Psoriatic arthritis will affect the DIP only, and it'll have nail pitting and dactylitis. So treatment is methotrexate or an anti-TNF inhibitor. Remember the fun fact that anti-TNF inhibitors can reactivate TB. Now we'll move on to septic arthritis. Different bugs will cause it depending on what age group you're in. So if you're less than 3 months old, Staph aureus, GBS, and gram-negative bacilli will be the most common. If you're greater than 3 years old, then Staph aureus and group A strep will be the most common causes. A patient with septic arthritis won't be able to bear any weight on their hip or their leg. They'll have swelling, limited motion of the joint, as well as a really high fever, greater than 101.3 Fahrenheit. On labs, they'll have increased ESR and CRP. They'll also have a positive blood culture, and if you aspirate the joint, their white blood cell count should be greater than 50,000. To diagnose it, you can also do an MRI or an ultrasound that I'll show you in a fusion. To treat septic arthritis, you'll want to drain the joint and also start IV antibiotics for Staph aureus and group A strep. A great empiric antibiotic is vancomycin. Septic arthritis can be compared with transient synovitis. So with transient synovitis, you'll also have a hip effusion. This will occur after a viral illness, and comparatively, they'll be much more healthy looking. They'll be consolable compared to septic arthritis. Kids will be very irritable, very uncomfortable. And then in terms of labs for transient synovitis, they'll have normal or just mildly high inflammatory markers versus in a septic arthritis, they'll be drastically elevated. Next, we'll move on to the hip. So developmental dysplasia of the hip is very common in breech babies. You'll see that there will be asymmetric gluteal or inguinal folds, and they'll also have a leg length discrepancy, and they'll also have positive Barlow and Ortolani signs. Legg-Clave Perthes. This is an avascular necrosis of the femoral head, and to diagnose it, you have to do an MRI. This is most common in kids like 3 to 12, and they'll obviously have hip pain and trouble walking, so they'll present with like a limp. Slipped capital femoral epiphysis or SCFE. This will also present with a limp or trouble walking, and risk factors for this will be an obese child. This will happen more so in adolescence. With SCFE, you'll have limited internal hip rotation. You can also have knee pain sometimes just from referred pain from the hip. To diagnose SCFE, you'll do an x-ray and you'll see a posterior displacement of the femoral head. And to treat them, you want to obviously have them be non-weight bearing, and you'll also send them to surgery so they can do surgical pinning of that femoral head. Let's say you have trauma to your superior gluteal nerve. This nerve innervates your gluteal minimus and medial muscles, and when someone walks, it'll be called a Trendelenburg gait, and the hip will fall towards the good side, and the weak muscle is on the other side, which will be the higher up hip. Elderly are prone to falls. They are at risk for hip fractures. If an elderly patient comes in with a hip fracture, it's very important to get the surgery done within 48 hours if they were walking perfectly fine beforehand and if they're stable in terms of their vitals.